Good morning. I want to thank for the kind invitation. Okay, I'm strong, don't worry. The topic is blister aneurysm. The blister aneurysm, the terminology is arterial aneurysms, and also, what do you want? It's okay, no problem, okay. It is arising from non-branching sides, mostly dorsal and anterior wall of the internal carotid artery. When you look at the studies on it, the people seeing those kind of aneurysm in the internal carotid artery, mostly medial part of the internal carotid artery, not the other part. First described in late 1970s, but the term of blister introduced by Takashi in the late 80s. You're okay. That's better, okay. Initial and most classic definition of the blister aneurysm is on the internal carotid artery, restricted to the internal carotid artery, but it is not anymore in that location. We are seeing blister aneurysm in every part of the intradural arteries, non-branching part of the segments of the arterial structures. When you look only the internal carotid artery aneurysm, it goes up to 6%. When you look whole intracranial aneurysm, it's about 1%. And then around 2% in all ruptured aneurysm. Pathogenesis is unknown. There are speculations, atherosclerosis, hemodynamic stress related to the hypertension, and anyhow, any kind of cause which creates arterial dissection is a possible pathogenetic factors. When you look at the pathology of these aneurysms, it's mostly resemble the pseudoaneurysms. And histologically, there are lack of disruption of elastic laminas. That's why it's enlarging rapidly, and they are rebleeding frequently because of that fragile wall cannot prevent re-rupture. This group is the worst group. Everyone has a lot of complication. Intraoperative complications, post-operative follow-up complications. Regrowth rate is the worst one, comparing all kind of intracranial aneurysm because of that histopathological features. So, I want to start the old case is 1997, the ruptured one. You are seeing a kind of circular shape aneurysm just on the anterior wall of the internal carotid artery. They sent the patient to us. This is almost a month later. Look at the morphology of that segment. Totally changed. That segment becomes fusiform. Also, the lower portion, posterior portion of the internal carotid artery affected. Even though at those years, we did our best with balloon remodeling and coiling, look at that. Just a year later, that disease portion includes whole circumferences of the artery. It becomes a fusiform enlarging aneurysm. Whenever you saw the case, of course it is not ruptured and passed away. You are seeing different morphology of this group. That's why some group try to classify the morphological aspect of the blister aneurysm. Of course, they started little blister shape and then goes to the fusiform enlargement. It is understandable theoretically because of the disruption of the elastic laminas and the weakening of the vessels can create fusiform nature. Most of the time, we are seeing those cases in acute stage. As we know, that simple coiling is not enough because we put the bioactive materials in it, with balloon remodeling, without balloon remodeling, it does not work. We will have re-rupture, we will have bad results. So especially for those group, fusiform, very wide neck, tent-shaped aneurysm, we started to use stents. And then we decided, we started to discuss about our antithrombotic protocols in acute stage by using stent. But anyhow, in those group, it is better to use a stent to prevent something. Like this, there are different technique of it. This is non-flow diverter stenting coiling technique. You are putting your coils and deploying your stent afterwards. It may prevent your intraoperative rupture because don't forget that aneurysms has no wall. So due to the radial force of the stent, you are pushing the coils and then have a chance to occlude that fusiform portion around the stent, and like this. And this is immediately after. And one crucial thing in those groups, every group is agreed upon, so it is better to do a control run, early control run, to see what's going on. Because when you look to meta-analysis of the blister aneurysm, the articles, that stent-assisted coiling, it has the worst outcome comparing the other endovascular technique. One of the best may be the parent artery occlusion, but that parent artery occlusion also has some problem because of that acute stage. You may have a good parent artery occlusion with a good collateral flow. Due to the vasospasm, you may have infarction, and in the articles concentrated on it also had bad results. So when we started to discuss about our bad results with stent-assisted coiling, we should start to discuss about parent artery occlusion results in the acute stage. In the non-acute stage, parent artery occlusion, of course, it is so clean, and you can foresee there will be no vasospasm or infarction. So in those groups, if we already decided to control frequently, we should avoid to give extra X-rays to the patient. That's why this is our strategy. Whenever possible, we are doing a contrast-enhanced MR angiography for follow-ups. And so you can, if you have a good MRI and good protocol, you may see there is no feeling around the stent, even though you have a stent metal artifact there. One problem coming from that contrast, because as you know, and as we know, the contrast accumulation of the brain is another problem. So you need to choose one of the follow-up protocols for your case. It is so easy that, okay, do a control angiogram every 3 months. There is a risk also, X-ray and angiogram risk. So everyone has different protocols on that manner. There is no fixed protocol in the literatures. Especially with diffuse supraacute hemorrhage, most of them are missing because of the less efficient protocols in the acute stage. Most of them, that tiny aneurysm are missing because of they're just doing MR angiography, they're just doing CT angiography, and they're letting the patient wait for a second follow-up. So it is mandatory to do a groin puncture angiography for all supraacute hemorrhage. It is the message to you. Another case, ruptured, they wait, and this is a month later, the patient came to us. This is a kind of classical appearance of that blister aneurysm, and it also, because it is away from the vasospasm period, the 1 month later, you see the stenosis just proximal to the aneurysm. It is more, we are thinking more prone to there is a dissection because of that intramural thickening and the reactions there. So in that non-acute stage, the flow diverter is a good tool in that tent shape, very wide neck, the aneurysm treatment. And we did it, and this is 3 months follow-up. Aneurysm totally disappeared. It is interesting, for the flow diverter group, we are really having a nice early occlusion of any kind of dissecting aneurysm and also the blister aneurysm. It is the observation. This is the 6-month follow-up. Another case, the old one, 1998. I followed this case. It's a ruptured case. The surgeon did a great job, clipped and wrapped, both of them. Because after clipping, they realized that there is no wall of that case, and they started to wrap. This is not a standard, the protocol of the surgeon. They only just clip. But the surgeons better to understand that weakness of the wall than us. So it is 5-year follow-up. See the enlargement of that clipped segment. That's it, no symptoms. This is 9-year follow-up of this particular case. That enlargement portion is growing. And this is 14 years of follow-up. She came to me because of a headache, different headache. And I decided to do an angiogram. This is the angiogram 3D. Look at the clip. Look at that succular, the deformation of that fusiform segment. And at those time, I decided to put the flow diverter to that case. And this is the flow diverter. And this is a year follow-up. Look at the clip, turn back to its original position, no gap between the clip and the stent, and the proper reconstruction of the artery. Of course, we need to look at 10 years after of this group, what will happen. Because the transition zone is still unknown. So the last year, that Arizona group, Spessler group, suggested to use this protocol for the internal carotid artery blister aneurysm. What they're doing, they are trying to do their best in the acute stage. They are clipping and wrapping. And after acute stage in the vasospasm period, they are taking the patient again and doing a flow diverter treatment. Because they are in the United States, they're using pipeline. And so this is the suggested plan of that internal carotid artery blister aneurysm. But what will happen for the other blister aneurysm, which cannot be clipped and wrapped? Another case, the marathon runner, after 15 kilometers, had a headache, still continued to run, and then their friends take her to the hospital, and then the radiology shows that kind of aneurysm on the same segment. Even immediately after stenting, you may see some change of the group. This is our observation. Look at that. It is not anymore that previous aneurysm, and this is only 1 month later. Early reconstruction of the artery is suggestive of dissections in general. So when you look at meta-analysis, this is the last year one, and then when you looked at the technique surgery is doing, and what we are doing is here, that dotted line, that there is a tendency to use stent, of course, not single coiling. And also there is a tendency to use in combination with flow diverter and the coil, because we didn't feel safe in this group. We are trying to do best from morphological point of view. So let me show some other blister aneurysm which are not in the internal carotid artery. This male had a facial paralysis and sudden onset. Look at that tiny dot here, perimesencephalic. The MRI shows that kind of hyperintensity on the same location. When you look at the non-contrast T1 weighted images, it is hyperintense, suggestive of hemorrhage. And this is contrast-enhanced imaging that those getting seen better on some vessel. What is this? While waiting, this is an MRI angiography, shows something here but not so obvious. And nothing on the thalamus. Why I'm showing thalamus to you? Because just 2 days later, in the hospital, she created a sudden hemihypoesthesia, and then this is a new MRI showing a new infarct on the left thalamic region, which is actually the territory of the anterior thalamic artery, that artery arising from the posterior communicating artery. And the right side, no P1, but the fetal type posterior communicating artery. And this is it. It is so obvious that that kind of dissecting blister type of aneurysm can occlude that anterior thalamic artery orifice from theoretical point of view. You can combine all the things together. So we haven't got tiny flow diverter at those times. While we are waiting that tiny silk from France, this is a month later, it started to heal itself without touching. This is a year follow-up. The patient is lucky. Another case, again the same infarction. I already published this. That's anterior thalamic artery infarction with the dissecting aneurysm of isolated posterior communicating artery. The same infarction and the same hematoma and the same aneurysm on the posterior communicating artery. Look at that. Again, I decided to occlude the posterior communicating artery. When I got the patient, I realized that the posterior communicating artery occluded by itself. And not always. This is the 2.5-year follow-up of this case. Another case, this is ruptured. This is the succular component. Again, the aneurysm, look at the junction of the posterior communicating artery is clear. Look at that. Again, the same infarction. And then you can coil it, you can occlude it. This is not the location you can wrap it, actually. So when you look to perimesencephalic rupture, supraarachnoid hemorrhage, there is numbers written in the literatures that is 5 to 10% of blister aneurysm. Are we really seeing those aneurysm? Like this is an obvious rupture. When you do a regular angiogram, you're all missing that tiny blister aneurysm, which is arising from posterior part of the basilar tip. This is the flow diverter treatment of this case, and this is a year follow-up and eradication of that blister. Of course, we can discuss the potential complication of the basilar tip flow diverter treatment. Another case, rupture. When you see the regular, well done, the angiogram, you're not seeing any. You need to go in details with 3D or flat panel detector CT angiogram. This is the blister aneurysm there. Again, the same treatment, one month later, it disappeared. Another one, when you look at the MR angiography, is nothing. 3D showing nothing. Those are the cases you should follow very frequently. I don't believe that protocol, if it is negative, especially MR angiography is negative, we need to wait 6 weeks or 3 weeks. You better do it very early, even in the same week. This is a week later, the same case. It's the coiling. 3 months later, look at that regrowth. Also the enlargement of the superior cerebral artery because of the dissecting nature. And then the recoil and the flow diverter. It's getting better, still some feeling, but she's in a good shape. Another case, pregnant, ruptured, MR angiography was normal. Should we wait? No. We should do an angiogram. Okay, we did an angiogram. It looks normal. Is it okay? Let's look at the tiny details of that flat panel detector CT. There is something here different than the other perforating arteries. When you look in details, actually the aneurysm is on the mesencephalic perforators, not on the basilar tip. So what would you do right now? To go in the mesencephalic perforator and occlude so? Actually, we wait, what will happen, and then 1 month later it disappears spontaneously. So we should also take care of the perforating arteries for that tiny blister-like aneurysm. And we should look and follow up frequently. Like this is the ruptured 44-year-old lady. Because of that enlargement, and we decided to put 2 neuroform in, I think, 2003. Yeah, 2003. We were believing that the 2 telescopic stenting preventing enlarging. Look at that. This is the post-stenting. No change, of course. This is just at the November in the same year. Look at that. In April, something happening here. Just simple fusiform enlargement turned out to be a kind of circular wide neck aneurysm. And at those time, we coil it with balloon remodeling technique. This is May 2005, looks good. This is the 2015, 10 years later, still looks good. So we should follow the patient frequently in the follow-up period. And in those mid-basilar group, I don't want to go in details because Jiwan will describe our mentality in Cerrahpaşa on posterior fossa flow diverter treatment. And thank you for your attention.
So maybe I missed, but in the acute phase today, what is your recommendation in terms of the antiplatelet treatment and placement of flow diverter? Do you do the flow diverter first, then give antiplatelets, or you give antiplatelets before you do the treatment? And another point, we tend to always have a balloon available ready to go when you're doing the flow diverter in acute phase in case a bleeding happens, to have a tamponade with a balloon. So I don't know if you think it's a good idea, but I think it's a good recommendation to have that. And the third question is, do you always coil on the acute phase, or you just place flow diverter?
Okay, let's start for balloon. It's regular routine things. We are having balloon in every aneurysm case. Not on the blister, it is ready in our hands. Yeah, it is a good point to have balloon to protect the patient in acute stage. For the second question, for the third question, actually, if it is coilable in the acute phase, I prefer to put some material in that enlarged portion to facilitate more thrombosis. But time to time, it is impossible to put the coils. How can you put the coils in a tiny posterior communicating artery, for example? Or that the basilar tip blister aneurysm, it is impossible to do so. It depends on the morphology of the aneurysm. That blister is not stay in that blister morphology. It is enlarging quickly and rapidly. If you have a chance to have a space to put coil, you can do it. And that putting the coil in the parent artery, squeezing the coil technique is kind of really very useful on that group. For preparation, we are actually not giving anti-aggregant at the beginning because we thought that the wading in the acute stage without touching the patient is more risky than doing the case first. So we are treating the patient in acute stage, first thing first. And then we are putting nasogastric and then preparing our antiaggregants. Most frequently, that the quick, the responsive antiaggregant drug is choosing for this. Maybe Effient, for example. But then after deploying the stent, we are giving from nasogastric. In that gap, 2 or 3 hours, we are supporting the patient with IV antiaggregant like tirofiban is Agrestat in Turkey and Europe. This is the strategy of us.
Thank you for your very interesting revision. One comment. The blister aneurysm or dissecting aneurysm is very, very problematic pathology because 75% rebleeding in the first 2 or 3 weeks. This is the problem. And your revision with the surgery and grafting of the aneurysm maybe is interesting, but I think it's very difficult. The imaging of magnetic resonance or CT scanner, you are the possibility sometimes in the special localization, you are the possibility to know maybe inside the vessel you are the blister aneurysm. Very, very interesting. And my question is, why many subarachnoidal perimesencephalic hemorrhagic is benign? No, it's not benign. Maybe you are the. It's not the benign pathology. Maybe it's the blister aneurysm in this patient. And do you think to prevent the patient, why not to use one stent, no, flow diverter, whatever you want, to prevent the possibility develop of aneurysm or rebleeding? The question is very, 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 very important because normally it's the young patient, it's not the old patient. Is the patient have the vessel is good vessel in totally branch of the brain, but have acute hemorrhagic in special localization. You analyze with the standard angio, you don't see the aneurysm. You need the 3D reconstruction, you need the vasco imaging or vasc imaging, or you need the magnetic. I think the analysis of this pathology is very, very difficult, but sometimes you are sure or you are the probability this localization have aneurysm. Why not to put one preventive stent?
You know, not for every aneurysm, but if it is possible, the cover stent mentality is the best in my mind for this group. If you can able to put the kind of cover stent, now the new cover stent is coming and new mentalities are coming, but of course that covered stent cannot deploy that basilar tube and other perforating rich areas. But in certain group, to get rid of flow inside that non-wall enlargement is the best way of treatment. But it is interesting that the flow diverters in combination or not in combination with coils has a little bit more better result than the other stent assistant coiling techniques. So endovascularly, we should also think to work with our surgeons to combine the treatment in the acute stage with wrapping, because clipping for those aneurysms is not easy. Their intraoperative rupture rate is really very high in the surgical group. It is something 40–50% intraoperative rupture because of that tiny aneurysm. The wrapping is something, but it is better not to trust the wrap, as I show you in an example.
You are experienced with cover stent? You are experienced? You are experienced with cover stent?
We used a lot in the past that Joe stent, but those are the proximal, most of them proximal aneurysm. We had some case in dissecting group. That's why we created a scaffolding cover stent technique. It was the coronary stent era at that time. And then it was a real hemodynamic treatment in that dissecting group. We had experience, so But nowadays, we haven't got good cover stand in our hands.
The other question then, this is, I don't know the answer to this, but if you cannot place coils, would you be inclined to use only one flow diverter or multiple flow diverters? Because the argument is that if you have only one flow diverter, no coils, because you can't place the coils, is that enough to protect? And I think
it is, because the second telescopic flow diverter, even it is 38 wires, just reducing the flow only 10 to 8% additionally. It is no. Even though you created a crowded metal in front of the neck, you're not getting a huge hemodynamic effect just because of it. As the previous speaker, Hans, mentioned about that, the gap between stent and the vessel wall is such important. If we are thinking and knowing that that group is a dissecting group, we should adapt our stent properly to the intima, because our goal is not the reducing the hemodynamic. Our goal is the creating an intimal reactions and thrombosis over the neck. This is different than sacral aneurysm mentality.
Do you have any experience or idea if the pipeline shield, the coated pipeline version, if this works with mono anti-aggregation, aspirin only, or Plavix only?
I didn't have any experience, so, but you know, it is a nice point. There are some groups, especially, you know, in Shanghai, we invited the physicians from Amman. They are not giving anti-aggregant, just giving heparin in that pipe shield group. They have good results, but I don't know. Do you have any idea, Dimitris? You are working on it?
Naci, I publicate my experience with patient with subarachnoid hemorrhage without aneurysm. And we see any 24 patients, and all patients have fenestration of anterior communicated artery and needle. We have patients with aneurysm and fenestration. And what do you think? It's not small. It's not small prepontine hemorrhage. It's very massive subarachnoid hemorrhage, and no aneurysm, no evagination, small 1 millimeter, no nothing, but only fenestration. What do you think? What do in this situation? Disconnection of anterior communicated artery, treatment, analyze, no, nothing. What do you think?
You know, at the beginning, Gazi Yaşargil and his students in Turkey are mentioning us that when they are operating in certain aneurysm, they're also seeing such blister and the aneurysm on other segments, and they had the tendency to clip those the enlargements, that tiny enlargement, and we are criticizing them why you are doing so. Actually, when you look at the surgical opinion on that tiny blister group in the literatures, you can find a lot of ideas on it. Maybe they found those group the pre-ruptured period by treating with the other sacral aneurysm. So first of all, we should enhance our diagnostic tools and mentality. We should stop just only talking about conventional angiogram. We should talk about 3D images and the best images which is given by our flat panel technology in the angio system. Maybe we can find more blister aneurysm in a non-ruptured period. That you're right, you are mentioning that fenestration combination with tiny aneurysm in the anterior communicating artery, and then the other colleagues also finding the same things nowadays, yeah.
I disconnect of anterior communicated artery with fenestration,
kind of
but I think this
occlusion, yeah.
border for critics.
We have done a study about fenestrations in cerebral arteries, and we did 3D angiograms in a lot of patients, and we found that in the anterior communicating artery complex, in about 30 to 40% of all patients, you can find fenestrations. So they are very, very common. If you look for them, you can find them. So there's no relation to any hemorrhage or whatever. It's very common to have a fenestration.
Yeah, yeah.